Good afternoon, everyone. Bienvenue à cet événement de l'ISSP. I'd like to welcome you on behalf of the Institute. I'm Monica Gattinger, the director of the ISSP. Pour ceux qui ne connaissent pas l'ISSP, il s'agit d'un institut panfacultaire à l'Université d'Ottawa qui se penche sur les enjeux de sciences, société et la politique publique. Today's event will be in English, but if you do have questions, sentez-vous bien à l'aise de les poser en français, and we will be sure, if need be, to translate them and respond to them as well. So it's a real pleasure to have all of you with us here today. I'd like to begin by acknowledging that the land on which the University of Ottawa sits is the unceded territory of the Algonquin people. And I would encourage everyone from wherever they are tuning in to acknowledge the territory on which they are gathered. Today, we've got a really interesting session in our Food for Thought series, where we are able to see the work of an Institute member live in action at the very early stages of COVID-19. One of our members, Stacey Smith, was called upon by the university to help with modeling and inform the university's response. Stacey is a relatively new member, but a very active member of the Institute. We're so delighted to have her with us. For those who don't know her, she has been very active in the area of modeling, has used some extremely innovative ways to engage people in modeling, including things like modeling for the zombie apocalypse and the like. So we're just delighted to have her with us this afternoon. I'm also very pleased that we have a really top-notch moderator for this session. We have Jacob Berkowitz. For those who don't know Jake, Jake is the writer in residence, well, virtual residence, I should say, at the Institute. Jacob is just a science communicator extraordinaire. He does a lot of work in science writing and communications. He's the author of a number of books and plays. He's been a tremendous support at the Institute. Again, really delighted to have him. So I'm going to be handing this off to Jake in just a minute here. But prior to that, we'll just let folks know that Stacey's going to give a presentation. Jake's going to be moderating that session, moving into Q&A, and then we'll close off the session with some words from Dr. Marissa Beck, who is the research director at the Institute. Marissa's going to fill you in on what we have coming up in our Food for Thought series next time. So without further ado, Jake, I give you the floor.
Thanks, Monica. Hello all, wherever you may be out there in Zoom land. I'm in a little town called Almont, about 45 minutes outside of Ottawa, on still unceded Algonquin territory. And I really appreciate Monica asking me to moderate this, the conversation we'll have after Dr. Smith's presentation. And I want to thank Raphael, who's doing the Zoom magic in the background, and Brendan, who helped organize this event. So a little bit about Dr. Smith and the presentation before we start into it. I had a chance to talk to her last week about her work, and absolutely fascinating. So she's a full professor in the Department of Mathematics and Epidemiology at the University of Ottawa. And what I found most interesting, and I'm interested to listen, to this aspect in today's presentation, is that in the big picture, Stacey is working at the intersection of mathematics, disease, modeling, and the social sciences. So it's this, forefront intersection of what historically has been mathematics and disease and their modeling using mathematics, but now also thinking about the more qualitative, what one might think of as fuzzy social sciences aspect that we've seen through this pandemic has been so important in terms of the transition of the science into policy. And I know that through talking to Stacey, she's been working at this intersection of science and policy for a long time, including a decade ago, working with folks at Public Health Agency of Canada and providing workshops on how, the mathematics of disease modeling. So this is something that's been top of her mind for many years. And I think it's particularly interesting at this moment. We're almost at the 1 year anniversary, right, Stacey, from when you did this initial research. And so we have even though we're still in the midst of the pandemic, in the pressure cooker, there's an opportunity, I think, today, and in your presentation and through the Q&A session, to really reflect on that intersection between research and its transition into policy, and then even into how we see things unfolding in the public sphere. So without further ado, I will pass it on to Dr. Smith for the presentation. And just to mention, after the, sorry, Stacey, I was about to pass the baton, but for the Q&A session, you'll see at the bottom of your Zoom screen, there is a Q&A button. If you would like to ask, or you're inspired to ask a question, please type it into the Q&A. I will be able to see it. And following Dr. Smith's presentation, I will use that Q&A session as part of the basis for the discussion. Over to you, Dr. Smith.
All right. Well, thank you so much for that great introduction. I'm very excited to be part of the ISSP, and particularly to give this food for thought presentation. So let me just share my screen. Okay, so I'm going to talk about basically what was happening in March last year. And so we probably all have some sense of what was going on. So in March last year, basically I was contacted by the upper administration of the university because they said, this COVID-19 thing is coming. We've kind of been seeing a lot of stuff happening really quickly, and we urgently need some models. There basically aren't any, and at least nothing that's answering the questions they were interested in. And we basically would like to know what we're going to do about this. So here's kind of just an outline of where we're going to go. Depending how much time I have at the end, I'm going to talk a bit more generally about mathematical models and how reliable they are, because I think we use them a lot without kind of asking the question too much about, well, did they actually work? All right, so I think we all know what COVID-19 is. Usually I explain diseases at the beginning for the general audience, but in this case, probably I don't need to do that so much, because this is obviously a very scaled up pandemic. And so I've been studying diseases for more than 20 years now. And this one is, in some sense, absolutely boring. It is totally not interesting at all, except for the scale, right? So, my colleagues and I at first, when it came along, we're like, is this interesting? We're like, nah, it's totally just textbook disease, just it's bigger, right? So that itself makes it interesting, I think. So a little bit of the timeline of this disease. So in January 22nd, there were 425 laboratory confirmed cases in Wuhan. The initial R0, which is the average number of secondary infections, that was estimated to be about 2.2. You'll see that changes as we go on, but it hovers around that value. By February 16th, there were 51,000 cases. On March 3rd, there were 90,000 cases. So you can see the rapid rise in cases. This is something that we haven't seen in a century. This just sheer scale of spread of a disease. And March 11th, there were more than 118,000 cases, and that's when it was declared a pandemic by the World Health Organization. All right, so that was really, in some sense, the wake-up call, I think, for lots of people. But at the time, still, if you kind of remember, things changed pretty rapidly, but it wasn't clear what to do. People were sort of like, well, it's coming, so what? Do we just catch it and kind of like hope for the best, or do we do stuff? So on March 12th, the University of Ottawa basically, well, they emailed a bunch of us, and it turned out everyone else was busy that day, and I happened to be free, so I ended up taking the reins on this. And they basically said, here are some questions. So, we urgently need to know some answers, because what are we going to do, right? Do we do nothing? Do we do something? If we do something, what do we do, right? And so the question specifically, they said, what combination of transmission rates and serial intervals make for the best case? What makes for the worst case? And what is the consequence for outbreak size and potential mortality on campus if we wait until case one physically appears on campus versus if we are proactive? Right, so this is basically sort of an insight into where they were. And this was basically just sort of, I mean, I've made these into sort of bullet points, but these are just, questions thrown out in an email. And it was sort of like basically a cry for help. So I was like, okay, yeah, this is exactly the kind of thing that modeling could do. Right, so this is where mathematical modeling is really powerful, because I think one of the best things about modeling is, well, it's cheap. That's one of the greatest things. I don't have to run giant clinical studies and so on. Right, we can run models right away. They're also pretty fast. Right, in fact, this was all done in one day, and they can predict the future, and so that's great. Now, of course, if I had perfect data, I would make a perfect future prediction. Right, but we never have perfect data. So that means, well, I have to do a trade-off. For imperfect data, what am I going to do for the future? I'm going to make multiple predictions. All right, so a few definitions here of who's who. So I'm going to define symptomatic individuals as people who have symptoms and are also capable of transmitting the virus. Right, so now usually those two go hand in hand anyway, but I'm particularly concerned about infectious individuals. I'm really thinking of it as a verb. These are people who can actually do something, they can transmit. There are also asymptomatic individuals who can also transmit, but probably at a lower rate, but that wasn't known at the time, right? They also may recover faster. Again, that wasn't clear, right? So these are all things that we had to take into account. What if they do recover faster? What if they don't, right? You can even put in what if they recover slower, right? So that's the great thing about modeling is we can try all these things at once. There are also latently infected individuals, which we call exposed. We're only considering death due to the disease and no replacement of susceptibles, right? So now, of course, in the long run, and we're obviously living in a long run pandemic now, people die for other reasons, right? People die of heart attacks, car accidents, cancer, whatever. And of course, new individuals come in. So, at the very least, babies are born. But also if you're considering a campus population, well, there's new students come in and they replace the existing ones. But for a short-term epidemic, we can basically ignore the kind of vital dynamics and say, I'm just considering the disease. So there may be death due to the disease only, but nothing else. Right. So what we're doing here really is we're making assumptions, right? And these assumptions might be reasonable or they might not be. The good thing is if we don't like those assumptions or somebody comes along later and says, I don't agree with your lack of replacement, well, we can easily throw that in, right? And that's where I think models are great because they're very robust to lots of different questions. So it's, it's very much scientific method. We can throw lots of questions at this and the models can easily adapt to them. So this is my snapshot, but we actually have gone on and adjusted this model for other things along the way. And we certainly can do for other questions as needed. Or we throw out the model altogether and start with the new one. And either is quite possible. All right, so here is a kind of like, illustrative version of the model. And so there are various compartments we need. So what we have here is there's a difference between variables and parameters. I'll explain a bit more on the next page, but basically there's variables, which are things that are changing and they are always changing. And then there are parameters, which are constants I happen not to know. So they might change, but they are not changing. So there's a subtle difference. And so of course I have to identify which is which, but the variables are the ones in boxes. So there are susceptible people, there are exposed people who have been infected, but not yet infectious. There are infected people, and they can be infected with symptoms, that's the class I, or they can be asymptomatic, that's class A, both of which can transmit to the susceptibles. And then there are dead individuals, right? So people can die or they can recover, right? So what happens is you get these splits happening. So first you're susceptible, right? And then there's beta is the baseline transmission rate. So the infectious individuals, right, can transmit, but so can the asymptomatic individuals, right? So these individuals also transmit, but maybe at a lower rate. So this eta here, it looks like an N, is probably less than 1. Although if we wanted to make it greater than 1, if we thought that was a possibility, we could easily do that, right? So we can adapt as needed, right? So there's 2 possible infections that are going on. For the latent individuals, they split in 2. So the fraction P tells us what fraction are asymptomatic and 1 minus P is not. Kappa, well, I've sort of said it's the rate of developing symptoms. Formally speaking, it's actually the rate of leaving the E class, because then they split into 2, right? So then they either become infectious individuals who can then do some infecting, or they become asymptomatic individuals who do some lesser infecting, right? Infected individuals or infectious individuals, they're the ones who die. So some fraction recover F and some 1 minus F fraction recover, do not recover and they die. And then the rate mu is the leaving rate of these individuals. So they leave I at rate mu, and then F determines whether they split into dead or recovered. The asymptomatic individuals we assume do not die from the disease, right? And again, if we wanted to do that, we could, of course, put an arrow in between the A and the D. So we could totally tweak it if we want. But based on the knowledge that we had at the time, and I think that's pretty solid, we assume the asymptomatic individuals do not have such a high viral load, so therefore they're not dying from the disease. So then they recover, and they may recover faster. So the same leaving rate mu gets amplified by some parameter alpha, which is probably larger than 1. So that's kind of an overview of the model. But let me put in the specifics. All right, so here is the model in kind of math terms, and this is really just exactly the same thing as the previous page. Right, so I've taken my model as a picture, and the picture I think is quite handy because I can talk to biologists and so on and get opinions on those, and they say, oh, you haven't put in this arrow, or you need this other class. That's quite a good visual, but then I want to actually work with it. I'm not going to put in too many math details in this talk because it's more for a general audience, but this is where I get into the weeds here. And what we have, I'll just explain it as we go. All of these are my variables. Let me just go back a page and see. So all the ones in boxes here, the reason they're variables is because they have derivatives. So what's happening is I'm differentiating each of the variables with respect to time. So there's also a time variable in here. So that's 1, 2, 3, 4, 5, 6, 7 variables. So 6 state variables plus time. And things that vary have derivatives. So that's how I know what's a derivative versus a parameter. Any other letter is, if it does not have a derivative, it's a parameter. So that means it's a number I may not know. All right, of course, I'm going to go put in data in a moment, but at the moment, I do not know it. So I don't know the beta, I don't know the eta, and so on. But once I figure them out, then they're a constant. All right, so that will be a constant. I could, of course, change that constant, but I would kind of take a photo of it at a different time. And that's now maybe a different constant, but I'm fixing it for that moment. All right. And so what's happening here is anything with a negative is decreasing. So susceptibles decrease by infection, either by infectious or asymptomatic individuals. The exposed individuals increase by either of those two, right? So they basically increase by infection. And then people stop being exposed and develop infection. So they go to either the I class or the A class. So the P splits them into the two. Then they leave the I class at some rate mu, whereupon that splits them into the recovery or dead class by F or 1 minus F. And then the asymptomatic individuals, they recover, but they just all recover and go into the R class. So you can see that every term is balanced here because nobody's coming in and nobody's going out. So there is no external entry into this model and there's no external leaving. Basically, nobody's being born and nobody is dying in this model. They're dying in terms of dead, but they're not dying for other reasons. Right? So I'm keeping track of the dead. The dead also, by the way, do not interact with any other term. Dead bodies are not infectious, so therefore that's not happening. Of course, in some models that is true, like in Ebola, for instance. So if dead bodies were infectious, we would just add an extra term here, right? So you can, of course, keep tweaking and keep tweaking. And I think the great thing about modeling is you can basically tweak to your heart's content. At some point, of course, you have to stop tweaking because it becomes too hard to analyze. Right, so you need to keep the model relatively tractable, although depending on your math skills, that could be quite a high level. All right, so what I'm going to do is basically just give us some results here. I won't go through the details of what we did, but here's the data that we had on March 12th. And so some things were known and some things were not known. So we knew that about 17% of the population was asymptomatic. The low risk death rate was 0.2%, and most individuals on campus are low risk. So campus mostly has very young, healthy people. Not everyone is young, of course, and I think we professors are the outliers there. But the vast majority of students are late teens, early 20s. So that drives it towards a healthier population. And even then, the professors, generally speaking, are under 70, and that was the cutoff for the high risk death rate. So we can basically assume that the low risk death rate is 0.2%. Now, of course, there may be some individuals who are immune compromised and they may be at higher risk. So I'm again making an assumption here. I'm generalizing to say pretty much everyone is low risk. If I don't like that assumption, I can go and change it, and I can either just up the average death rate, or I could put in the second class for immune compromised people. I may not know who exactly is immune compromised, or more specifically how many are, but I can make some estimates if needed. But for my March 12th thing, I just said, okay, I'm basically assuming everyone is basically in the healthy group. That's also in some sense kind of a best case scenario. So that's another assumption to watch out for. And I think it's very good ethically to be clear about what these assumptions are, so that anyone making decisions has the full information to say, okay, well, I understand your results, but what about the missing bits? We had a 3-day incubation incubation rate with quite a large range at the time. Takes 20 days from onset of symptoms to death in the young population. That was the number is higher if it's an older population, but this is for our basically young and healthy population. By this point, Arnold had been updated to 2.35, although there was quite a bit of range here. And our campus population is 42,000 people, but of course, not everyone is on campus at any given moment. And as I said, there's some heterogeneity among the campus population. So again, we're kind of taking a snapshot with some assumptions and seeing what happens. All right, so just as a caveat, data is often scarce and unreliable in the early stages of a fast-moving epidemic, and sometimes even in other times. All right, so these were the most accurate numbers that we had at the time, given all these caveats that I've mentioned. Okay, so since I know R naught, all right, I can backtrack and try and figure out the beta values particularly. So the things we didn't know were the beta, the baseline transmission rate, and also the amplification due to the asymptomatic individuals. So how much less transmissible are they? So that's basically the eta, and how much faster do they recover? And that's the alpha. Right. So basically these three things were the unknowns, but we have a relationship here. And what we can do is we can basically try some different versions, right? What if it's the best case scenario? What if it's the worst case scenario? What if it's something in between? Right. So here are essentially three snapshots of this is what if asymptomatic individuals have no difference to symptomatic individuals, right? And that was something that was wondered at the time, although it was suspected it wasn't true, and now we know it's not true, right? But what if they basically transmitted exactly the same, right? And in that case, you would measure a beta. What if asymptomatic individuals did not infect susceptibles? And that was another thought that people had. They said, "No, maybe if you're asymptomatic, you can't transmit." And we now obviously know that is not true at all. In fact, that's highly untrue. But it gives us an extreme case, right? So obviously, we're very likely to be between these two values in reality. So we picked something in the middle, which said, okay, asymptomatic individuals are, say, half as transmissible, but recover twice as fast, right? So that will give us some values which would find a beta in the middle. One thing you may notice is that if the asymptomatic individuals transmit as much as symptomatic individuals, it's actually a lower beta than if they don't. Why is that? Well, because if they don't, that means the relatively few symptomatic individuals are much more transmissible, right, as a result, because they're doing all the work. So that means actually the beta that would sustain that R naught would have to actually be higher to compensate. Right, so that's why it may appear backwards. All right, so because we didn't know these values, we ran several simulations to try and determine possible long-term outcomes, basically to answer the questions that were asked, both in the absence of interventions and also if we, say, cut contact rates by 50%. Now, we know in reality we did more than that, cut by much more than half, but at the time it was not known at all. And there was a real thought of what if we don't do anything, right? So that was one of the questions. So here is basically a plot of this is where index case 1 appears. So this is, first symptomatic case appears, and then you can see this grows. I'll put a linear scale in a moment. And what we see is the first death would appear on campus about 115 days later. So, and this is the worst case scenario if we do nothing. So let me plot the time series for this. So this is the inset here is basically the same as before. That was on a log scale. This is on a linear scale. So what you can see is you're talking about 6,000 cases on campus at the peak. First case appears day 115 and leading to 63 deaths on campus. You can also see that in the long run, most people get infected. The number of people who remain susceptible is very low at the end. So a lot of people get the infection and recover. So the red here is the symptomatic cases. The asymptomatic is a bit lower, right? And this is a kind of classic epidemic curve where the disease would come, kind of do a lot of damage and then go away after about a year, right? Now, of course, it has not gone away after a year. So but remember, our model was built for kind of short-term predictions, right? So what happens is as the longer you go on, the less reliable it becomes, right? So is it going to be absolutely 63 deaths? Certainly not, right? If we did nothing, we would say, but surely after 500 days, you would start to have replacement of susceptible. So you would tweak your model. So this gives us an idea without nailing it down necessarily to say, well, we're not going to expect exactly 6,000 infections or 63 deaths, but what we're expecting is somewhere in the ballpark of this. Okay, so that's our worst case scenario, right? What about a better case scenario, still without interventions, right? So here we see that the first death occurs later, it occurs day 150. And if I put out the time series, then you can see it's a little bit different. We now have, well, in fact, we have more cases. We have 7,000 cases, but 58 deaths, right? So this is our best case scenario. And well, the cases have gone up a bit because what's happening is asymptomatic individuals are transmitting more. And so there's more asymptomatic cases, but there's less deaths. So, and the first death appears a bit later. Also, not as many people get infected in the first place. Still a lot, but not quite as many. So this basically gives us an idea. Well, the truth is probably somewhere in between, but this is, I think, pretty clear that you're going to have, something of a disaster on your hands if you don't do anything. All right, so this just sums up what I said there. Let's move on because we said that already. What if we have the contact reduction? So what if we go to 50% contact? And actually, there was some talk that we might go to 3-day weeks, for instance, right? And so, well, that's obviously not 50%, but that's in the ballpark. So what if we have less interaction of students? Well, now you would see there's a much longer delay, and the first death would occur about day 450. So that's much later. Right, and the picture is quite different, right? We see here now the number of susceptibles remains fairly high, right? The number of recovereds, in fact, is less than the number of people who, never got touched by the disease. The total number of cases hits only 700 and 25 deaths. And this is the worst case scenario when we do 50% contact reduction. So you can see there's a massive change. There's an order of magnitude change in the number of infections here, right? And the number of deaths is more than halved. Now, is 25 deaths on campus acceptable? That's kind of really up to the upper administration to decide if this is something that is doable. And remember, this is in young, healthy people, right? It may, of course, be worse if we include immune-compromised people. So, obviously not going to be exact numbers, but it gives us an idea. Basically, if you halve the contacts, you halve the deaths. Okay? You more than halve the number of cases, of course. You cut that by a factor of 10. Okay, and the best case scenario with 50% contacts, well, now we're talking a very significant delay. Right, so this would be much, much longer. This is order of years now before the first death. And you can see that the peak number of cases in this example would be 25. Right, so that's obviously much, much lower and only 5 deaths. Now, of course, this is talking 5,000 days is a very, very long time. We would have to change our model at this point. So if I was going to take this much more seriously, I would say I would probably put in that replacement of susceptibles. If campus was literally going to go to 50% contact reduction, so I guess we go to 2.5-day weeks, right? Then I would redo the model, adding in more things, because it looks like basically what I'm learning from this is the timescale matters, right? If it's a basically short outbreak where we do nothing, it might pass quickly. If it's, the more we reduce contacts, the longer this epidemic is going to go on. Well, we totally see that, right? I think, if we'd done nothing, this disease might have passed through, killed a lot of us, and we'd all be out of it by now. But of course, we don't want it to kill people. So, we're prepared to live with a longer epidemic, and that's what we're doing. All right, so just to sum up, right, we had 115 days to wait for the first death versus, 115 days versus 450. And we got, 25 deaths if we reduce contacts by half versus 63. And in the low transmission case, we would eventually get 5 deaths versus 58, which is quite a significant improvement. So what we see is that reducing contacts is really critical, right? And of course, in reality, we reduce contacts way more than 50%, right? We didn't reduce it to 0, but we reduced it a lot, right? Okay, so, well, I delivered this at about 2 in the morning on, well, technically March 13th by that point. First thing next morning, they closed campus entirely, right? And they basically said, we are shutting everything down, right? And we were one of the first campuses to close. It basically remains closed, except for essential research. There was functionally no talk of it really reopening in the fall. I mean, there was sort of, at the time they said, we're closing for definitely the remainder of the semester and also the summer. And then later they said, yeah, the fall as well, and then the winter, right? So other campuses in other places in North America, in cities that are doing much worse have reopened. We did not, and I think that was actually a really wise idea. So of course, now there are some things that have to happen, and campus is not just for students. There are essential labs that can't be left unattended. So of course, these are managed carefully. But we've done much more than this 50% contact reduction. Okay, so now this is not the end of the story, because there's more information has come to light. And of course, we are actually living in global lockdown. There haven't been any deaths on campus, but there was a case on July 17th, a member of the support staff that was announced on July 20th. And so there was a case on campus. So if you like, the clock is ticking, although I think, if we kind of continue on, well, I think a lot of the assumptions have changed, right? The mixing of students that we had before, it's not just there's less students, they also mix in different ways. right? So the mixing that we put in, basically that beta SI term that we had, that assumes people are well mixed. And that was a very good assumption before March 12th, but that's not a good assumption now because people are much more careful and there are masks and there is distancing and so on, right? So there may be mixing happening, but it's a different kind of mixing. So, if we wanted to talk about perhaps, models for reopening, right, we would come up with a different form of some of the things, right? So certainly quite doable. All right, the outbreak in Ottawa, as many of us may know, has sort of, been pretty typical. There were significant infections in hospitals, retirement homes, and long-term care facilities, but not that many in the community. Here's kind of a snapshot in the summer last year. So at the top here is kind of cumulative cases. Here was number of deaths, which kind of had plateaued by about the end of the summer. And you could see that here is kind of the sporadic outbreaks, kind of like you had this sort of, initial rise and then it kind of reduces. The black here is institutional outbreaks. So these are institutions where they tend to be, either old people or sick people. So campus would not have probably been the same as this because it's different, although there are many more people in campus. So, we see these big rise in April, May that eventually comes under control. And then you sort of see these, later sort of mini waves happening where kind of it gets brought in from outside because the community stuff is in green here and that remained pretty low. All right, so I'd actually picked this in August because I was first preparing this for a conference talk in August. So I was like, oh, this looks great. And of course, then schools reopened in September and things really took off. All right, so the first wave basically was done by July. We had about 2,000 cases, about 260 deaths. Sporadic cases had peaked in mid to late March. Institutional outbreak kind of peaked in April. So, that was kind of our first story. And here's I just basically want to present a graph of what if we reopen campus with kind of like appropriate distancing. Well, we kind of might see this is the worst case scenario, right? And when I say few symptomatic individuals, what I mean is anyone showing symptoms, of course, would be staying home and, obviously wearing masks and so on, even if they were not home, but basically essentially not interacting. It's essentially driven by the symptomatic individuals, but you would still see an outbreak, just a small one, right? And, on a similar timescale to the first case where we're talking 100 and something days before the first death, but, maximum 2 deaths here. So, well, is that okay? That's a good question, right? It's, again, up to kind of political leaders to decide, is 2 deaths acceptable? Should we wait to 0 deaths? Well, we could do that, but of course, then we're completely locking down. So there's all kinds of questions that get thrown up here. All right, so yeah, basically we keep the number of deaths at 2. It takes similar time for the first deaths, but the number of symptomatic individuals is much, much lower. So instead of 6,000, we're talking 3,000. All right, and I'll just mention the other cases produce similar results. So there were very similar orders of magnitude there. Okay, so some limitations from this modeling was this was a snapshot in time. The data that we had was limited. And the model does not consider vital dynamics, so it didn't include new susceptibles, and it kept the population constant. As things change, that's, the new susceptibles are probably not coming to campus, but, things can change, right? So there's maybe fewer international students, an increase in distance learning, of course, because of lockdown. So that changes the nature of learning. Even if we reopen, these things are probably still going to be in place. All right, so benefits of this model were its rapid development. So it was done, in about 12 hours, really. Its flexibility, because, the data was lacking, so we can consider multiple cases. And then its ability to directly answer questions that were posed by the university administration. We certainly gave very clear answers, I think, to the specific questions they were asking. We come up with a few other things as well, but, the questions they're asking of how long are we waiting to see the first death after the first case, we can definitely answer those questions for basically best and worst case scenarios, right? And what's the outcome of being proactive versus not? We can see that too. So what you see is here's the role of models during a fast-moving pandemic. Right? They can make predictions, they can inform policy, and generally speaking, my experience has been when they are good at informing policy is when people are kind of integrated from the beginning, right? It's not enough to just kind of make a model and send it out into the world and hope that somebody reads the paper and decides, yes, I totally agree with what you're saying, let's do it. It doesn't work that way. Where I've had a lot of success is when I actually work with people and we build these models collaboratively from the ground up, to like answer specific questions and basically calm people around math, because math can be pretty scary. And I've definitely had a lot of conversations with people in, Public Health Agency of Canada and so on, where they are kind of a little bit terrified of math, I'd say, and yet models are kind of useful and they know they can be useful, but they kind of don't want to see the details. So it becomes a sort of dance that we do a bit about, not showing them too much math, and yet of course they want to see what is actually happening. So that's a kind of ongoing conversation that I'm having with people. All right, so let me just sum up, and I think I may be at time. So these results illustrate the interface between theoretical mathematics, numerical simulations, real-world data, and human behavior. I didn't talk too much about human behavior, but we can add stuff in as needed. The math gets a bit more complicated. So modeling a disease during the very early stages of a pandemic means we can assess a variety of potential scenarios using the information that we have at the time, and also potential information that might occur. All right, so we can run best worst case scenarios, things in between, and so on, to basically do a trade-off for the missing data. And so then decisions can be made by the administration armed with useful predictions. Okay, so my second part, which I think I don't have time to go into, so I'll just come back to the Zoom again, was basically just about a survey of how models have been useful in the past. I'll just briefly sum up. We basically looked at models for previous epidemics, so SARS, MERS, the 2009 H1N1 outbreak, and Ebola, and basically tried to get some principles of like, well, how good is the modeling? When is the modeling good? When is it not? So, a lot of models were done early in these pandemics. And of course, we now have the luxury of looking back and saying, well, were they accurate or not? And it turns out they are surprisingly accurate, right? I sort of, I'm a bit biased, and I thought, oh, they're probably somewhat accurate, but I was surprised at how accurate they were. They could predict the R naughts really well. They could kind of, in one case, they could really predict even just the number of cases almost precisely. And where they are not accurate is in predicting second waves. So they're really good for the first wave. They're not so good at predicting, will there be a second wave? If there is a second wave, when will it occur? And how bad will it be? All right, so essentially you have to kind of treat a second wave as a just totally new first wave. So you basically start all over again once that wave starts, then you're pretty good at predicting. And the models that we found, which were generally the best, were those that include stochastic effects. So when there was basically randomness built in, so that, basically dealing with the uncertainty in the parameters and so on. But when you can take into account those things, models became really, really good. And in fact, there's a great one that predicts MERS based on 55 cases. So they took only 55 cases, which is a tiny number, and they were basically able to get amazing predictions out of that. So models have had quite good success in the past, and so that gives me faith that they will have some success for COVID going forward. All right, so I think I will stop there because I've got to my half hour. So I'm happy to take questions and happy to talk more about COVID or modeling or pretty much anything. Thanks.
Okay, wonderful. Thanks so much, Stacey. So if you do have a question, you'll see in the bottom of your Zoom screen, there's a Q&A button. If you open that up, type in your question. I will use those as the basis for a discussion with Stacey. If you would like your name, I'll do the questions anonymously. I'll introduce the question anonymously to you, Stacey, unless you indicate directly in your Q&A text that you'd like me to mention your name. So I'm going to start off with a question, and I empathize. I guess I've never had such empathy with a mathematician before, because as a science communicator, there's a rubric or a rule of thumb that we use, which is for every equation you lose half your audience. And I never realized, but if you're a mathematician, then well, you've got to use the equations. So we got deep into the weeds, and I'm going to pull you back here, because you mentioned a term. You talked about, when you showed us your equation, you talked about the missing bits, and I'm wondering if you could talk to the whole question of how do you insert behavior, all of the kind of complex behavior that you alluded to in your last comment there, into these models. I mean, and can you even include the kind of complex behaviors we've seen during the pandemic?
Right. Yes, it's a great question. And I think the answer to the second part is, can you, I don't know, right? Can you precisely predict every human? Absolutely not, right? It's just impossible. Humans are totally random and totally unpredictable. Can you generally predict human behavior? Absolutely. Humans are completely predictable, right? And both things are true, right? So an individual person is really hard to predict. Average humans are really easy to predict. So what you have to do is kind of look at basically if you break people up into groups, so for example, if we're talking about a vaccine, right, so that this is some of the modeling that we're going to do, right, there are people who are enthusiastic about the vaccine and going to get it, and there are people who are not enthusiastic about the vaccine, let's say, and not going to get it. If you look at these groups and you say, well, the vaccinators, what are they going to do? Are they going to change their behavior? Are they going to stop wearing masks? Are they going to have parties and so on? So the vaccinators might do one thing, and the non-vaccinators, who don't vaccinate for whatever reason, I don't really care what their reason is, but if they're not vaccinated, they may be immune compromised or they may be anti-vaxxers or whatever, but the non-vaccinators, what are they doing? Are they increasing or decreasing their risk behavior? And they may, of course, each group may go each way, right? They may say, well, now there's a vaccine and other people are getting it, so I'm going to go have parties and do whatever. So, each group may do it, or each group may decrease. The non-vaccinators may say, well, I don't have the vaccine, so I better be more careful since I haven't been vaccinated, right? And the vaccinators may have more contact with the medical system, which says, listen, just because you've been vaccinated doesn't mean you stop wearing masks, doesn't mean you stop social distancing and so on. So they may actually decrease their risk behavior. And you can look at the basically increase or decrease in both. So that way you've kind of taken all the randomness that might happen and bring it down to, say, 4 scenarios. What if it gets better or worse in each of those 2 groups? And that's a way of kind of, making this problem more grab holdable, really, right? Because overall, what are they doing? And of course, the individual components of these groups may be very different, right? Especially the non-vaccinators. Some people, the people who are anti-vaccines may be, much more likely to have parties and, flaunt the rules and so on. But of course, the people who are immune compromised and cannot get vaccines may be much more likely to adhere. And depending on the makeup of these 2 groups, the result may go up or may go down overall. And so because you can't predict that, you say, well, let me just account for all the scenarios. And that's one way of putting in kind of the behavior part.
Okay, I have a question from one of the folks on the Facebook Live here that I think really gets to the reality that we think for the executive team at the University of Ottawa, who received your report about a year ago. And the question, I was going to read it here to you, Stacey. It says, regarding the importance of this, your work to decision makers who don't usually want a lot of extraneous detail, how do you communicate your caveats to them? For example, assuming the entire population is low risk.
Mm-hmm. Yes, I think it's very important to highlight this, right? You can't just kind of bury it in one line in the report, right? You have to sort of tell them you're doing it. You have to do it. You have to tell them you've done it, right? It has to be really highlighted here. I think it's like they always say, like there's that media cycle, right? You present your results, then the media picks it up and they ignore all your caveats, and then they say like, well, most of the time this happens, and then the next media thing is like, all of the time this happens. Like you lose the nuances really quickly, and that's a real danger, I think. So yeah, that is, I say, one of the ongoing communication challenges that I think like we all face as scientists, and I think math in particular, because people just glaze over the details, right? They don't want to look at the equations. They want to say like, okay, but just give me the answer. But the answer is not just the answer. It's got all this nuance here. So I'd say, yeah, it's certainly a matter of basically really reinforcing it and saying like, listen, we are really basing this model on the fact that we're assuming that the population as a whole is low risk. And I think that's a safe assumption broadly, because as a whole, it probably is. But more nuanced, you might say, I really maybe care about the whatever 10% of people who are not, and we really may want to think about that, and this is not included in our model. So I think by basically highlighting it like that, and you can do that informally, or you can do it more formally, is really important. I'm certainly very much encouraging you. You want to list all your limitations of your modeling, both implicit and explicit. So sometimes you've made an assumption and said, okay, I'm just assuming that whatever, my every student is on campus at any time, for instance. That's an explicit assumption. But another assumption built into the models is that the population is well mixed, right? So the form of the equation we choose assumes that people are moving around explicitly. What it assumes is that an affected individual has an equal chance of infecting any susceptible. Right. Well, that's not really true, right? Because I don't really go over to kind of the arts section of campus that much, right? So I'm not going to infect anyone who's over there, right? And they're probably not coming to the math building too often, right? So you do have a heterogeneous population, but the model is assuming of this homogeneous population. And well, there's been lots of work done about how to determine when is this valid and when is it not. And for respiratory disease, it's broadly valid, right? So because basically I'm breathing and leaving fomites around and so on. So probably that's roughly right. If it's a sexually transmitted disease, it's completely not valid. right? And so, like I can't infect anyone who's not a sexual partner. So this, you have to change your underlying model in that case. And I've seen people, apply respiratory kind of models to sexually transmitted diseases, and it doesn't work, right? Of course, because you have very different populations there. So I think trying to like consciously dig into those things all the time and highlight them is really crucial.
I'm interested to just, there's a question from me, and then we'll get back to the Q&As on the Facebook Live. That you mentioned something at the very beginning of your talk that I found very evocative. You said, this was from a researcher's perspective, this was boring except for scale. And I think that for those of us who aren't disease modelers, might go, wow, that's it's who are living kind of the experience. That's I find a very powerful thing to hear. And I guess I'm wondering about your kind of thoughts, feelings, reflections that you've had over the last year. I mean, boring except for scale, but now that we have been living through, the first global pandemic in our lifetimes, what kinds of reflections you've had about the kind of the importance of the work you do? And I'm particularly interested in how, in the insights you've had on how the work you do is integrated, into public policy.
Yeah. I mean, in some ways, you want to be in a boring pandemic, right? Because a boring pandemic, you can make predictions about much more easily, right? So when something comes along and it overturns everything, I mean, HIV basically, when that came along, it overturned like, a lot, like our knowledge of genetics and stuff like that. Like, the central dogma of genetics said that DNA can unwind to become RNA and RNA cannot combine to become DNA. Well, that's precisely what HIV does. So we kind of had to throw everything out at the beginning. So HIV was totally fascinating, but that's a bad epidemic to be in because it wasn't just that. There was so many things about just even the nature of infection we just didn't even know were possible. Whereas this one, it's like, looking back at, various publications before this epidemic, everybody's predicting kind of like, well, the next pandemic will probably be a respiratory illness. It'll probably be flu-like in its symptoms. It will probably look like exactly what it did, right? And so that means, what do you do about it? And you can look at papers from, like past 15, 20 years, and they all list like the interventions that are needed, which is like, basically like masks, distancing, quarantine, treatment of, symptomatic individuals and vaccines. Basically all the things we're doing, that was all written in written in stone for a long time, I'd say. So in that sense, we knew what to do pretty quickly, and it's just a matter of doing it. Right now, of course, doing it is a different question because people are not so good at necessarily following these instructions or believing them and so on. We could have acted much more quickly, I think, and because it was boring, right? Because we knew exactly what to do, right? We could have started acting in February, for instance, and we didn't. Right? If we'd started wearing masks in February, we would be talking about a very different situation now. Right? So we kind of missed our window of opportunity. So in that sense, it's and I think also, I mean, certainly at the time, a lot of disease modelers were saying things, but not being listened to. And, I mean, like, governments often were like, well, let's grab a doctor and ask them. And I sort of feel like that's like, I'm planning a vacation. Let me, kind of ask my auto mechanic versus a travel guide, right? It's like you're looking at someone who, knows your body very well, is not necessarily an expert in the spread of diseases. Right? And so I think, there was expertise out there, but it wasn't known about. And so it's very hard to kind of communicate in that sense because, you're trying to reach people who are not necessarily looking for you. It's quite a mismatch there. Yeah, I mean, like a lot of modeling was taken into account though much later actually. So I think in April, May or so, then the government was releasing their models actually, or at least releasing the results of their modeling. First was provincial governments and then a federal government. Basically we're like, okay, we're going to make our predictions, public. And that was a big moment because I'd never seen anything like that before. So that was really interesting to me actually, was they suddenly were taking modeling really seriously, a little bit late maybe, but better late than never.
Yeah, there are a lot of questions coming in, Stacey, and I'm going to combine two. And I'm already apologizing in advance to those whose questions I don't bring because I'm trying to keep them at a higher level. And I don't know if after this is over, if you're going to be able to go into the Facebook Live questions stream and answer that. But if you are able to, that would be awesome, cool. Because there's some very kind of interested, more detailed questions. But someone asks, and I'm going to combine two, so I'll read the bit that they said. Stacey, that was fantastic. I want to push you into a forward question. You've been deep in all the numbers and options in a way very few have. when do you expect U of O to return to normal? That's the first, question. And I'll contextualize it within the second one, where someone says, what guidance directions would your model and others you provide to public health authorities at the municipal, provincial, and federal level? So really kind of what's the guidance for the university, and then for, kind of administrative political units larger than that?
Yeah, this is a good question, because of course, an ideal answer is like when the epidemic has gone to zero and stayed there, that would be great. But of course, that may be a number of years, right? And so do we want to be in lockdown for 5-10 years? I don't think so. On the other hand, we don't want to open up too early. So it's the Goldilocks problem, right? We can't do it too early. We can't do it too late. We want to do it just right. And knowing what's just right is really hard to do. I think, some things are, what does it really mean to have recovered, right? And so, that's a tricky one. I think, a baseline answer is like, when we've hit 0 cases for 14 days, then we can start reopening, right? Then we can start doing stuff. And we haven't gotten anywhere near that, right? And, we really shouldn't have been coming out of lockdowns until we're at 0 cases. And I think good evidence for that is that they've done this in many countries, right? Well, at least some countries. They've done this in Australia and New Zealand, and some of the Asian countries like Vietnam and South Korea have managed their epidemics really well. And we have not managed ours so well. And in part, I think our metric for when do we reopen isn't good. Our metric is kind of like, oh, cases are coming down. Like, that's not a good idea, right? It's when cases get to 0 and stay there. So for Australia, I'm from Australia, so my Facebook is very bifurcated, right? Half my Facebook is my Canadian friends and North American friends saying, oh, this lockdown, when will it ever end? And the other half is Australia being like, hey, it's great to be back to concerts. And it's, my brother told me that on New Year's Eve, the government was encouraging them to have parties. They said, look, enjoy New Year's Eve. We're out of it. Let's do it. And this is not a place that was untouched by it. In July, Melbourne had exactly the same number of cases per day as the UK. And the UK is an absolute disaster right now. And in Victoria, where Melbourne is, they locked down hard. They did it properly. They were, like 23 hours a day, you are locked in your house. You do not go out except for 1 hour a day. One person in your household can go out, and they can do all the grocery shopping and exercise or whatever you're going to do outside in that maximum 1 hour. And it was policed. It was, neighbors calling the police on neighbors. And if you see a car in the driveway, you call the police, and, you send people over. If you're driving down the street, you get pulled over. Like, what are you doing here? And, this isn't happening here at all, right? And so, I remember in April, I was, if I had to drive to the grocery store, there's no traffic. I was like, oh, the roads are empty. The roads are not empty these days. If I drive to the grocery store now, I was like, why are all these people on the road, right? And, over Christmas, we saw massive movements happening, right? And so basically we've sort of decided, as a society, that it's not really worth it for us to go to 0, right? We're saying well, we're basically prepared to live with COVID, and we complain about it a bit, but we're not prepared to do the hard work for it. And so that makes it really difficult to kind of get to reopening stuff, because it's well, I can say all I like, hey, you should get to 0, but if people are not going to follow it, in a sense, what is the point, right? So now I think that there is a point. I think that actually, if we as scientists were stronger in saying, listen, this is serious, and we are not supporting you until you actually do these policies, then I think the government would listen a bit more, because they do kind of listen to us in the sense of they'll cherry pick a bit, right? If we're saying a bunch of things, they'll kind of pick out what they want a bit. But if we were more united in saying listen, you should not be reopening at all, schools should not be open, and so on, right? Schools are a classic example, right? Pandemic Preparedness 101 says close the schools at the very beginning of a pandemic and you open them at the very end, right? They should not have been opened in September. That was crazy talk. And, look what happened in September, cases just blew up, right? So, this stuff is all in some ways quite predictable. On the other hand, getting it into the minds of the people who are actually pulling the levers is really, really tough.
But that bridge between the mathematical modeling and actually the public policy, is there actually debate though amongst modelers about yes, you can say we should close the schools at the beginning and opening at the end, but are there modelers who say, well, actually the psychological impact and the impact on families of doing that is too great, and therefore not? So I guess I'm coming back to you and saying, well, if we all got together with a common voice, but is there actually a common voice? Is it just as diverse?
Yeah, I would say yes. There certainly is debate, of course, because trying to get any academics to agree on one thing is really challenging. But I think that the debate is not like, oh, it wouldn't be good to get to zero. The debate is often like, well, it's never going to happen, so let's just work with the system we have, which I personally think is a bit too soft a response, because I think that like it's certainly never going to happen with that attitude. So yeah, people are sort of saying, well, like the government will listen to us anyway, so let's try and work with them to deal with like best case scenarios for reopening schools, for instance. Right, and so they're sort of working on that level. So yeah, I mean, of course there's a lot of voices. Of course it varies a lot, and yeah, there's not really a cohesion, and I think there could be, and there perhaps should be. In terms of the underlying understanding, though, I think that's pretty clear. Everyone is like, well, yeah, obviously, if we just shut down, if you literally didn't leave your house for 2 weeks, COVID goes away, right? But of course we have to, right? It's just the level of how much we have to, I think, is sort of here when it should be down there. So yeah.
Okay, I'm going to read another question, Stacey, and this is in the Build Back Better theme. The question is, what kinds of data or data collection systems would you like to see in the future that would help with your modeling work? So imagining, that we're going to use this experience to actually improve the data collection system for the work that you do.
Yeah, that's a great question. I think more explicit data on kind of the heterogeneity of the populations would be great. So kind of, I think we just sort of generally tend to say sort of, well, susceptibles are either one group or possibly two groups, is maybe like high risk, low risk or something. But could we stratify that a lot more? And of course, we know some information about that, but I think like more information about the people who are not being infected would be great, right? So that involves more kind of like, more soft science stuff, right? More people kind of going out and doing surveys and so on. And sort of, finding out behavioral attitudes would be great, right? Kind of like, and it's a really tough one, right? Because if you say to someone, hey, are you adhering to the COVID rules? People say, of course I am. Of course I am. I never leave my house ever, And we know well from, say, for example, sexually transmitted diseases. If you ask people, are you using condoms, right? And they all say, oh, yes. And we've done cross surveys which blatantly prove this is not true, right? So people will often lie to researchers because they don't want to look bad. And when you bring in this kind of morality sort of aspect, right, even if the researcher is like, I don't care, I just want the information, of course it doesn't feel that way to the people being asked. So having that kind of information would be great. And I think also more heterogeneity in the infected population too. Like, are some people spreading more than others, right? Are there any, factors here? And that doesn't seem to be the case here, but it certainly was the case in the first SARS. In the first SARS, there were super spreaders. So some individuals did a lot of damage. Some individuals spread it massively, and most individuals didn't spread it that much. And so we had this really kind of two-tiered system here, and trying to identify who those individuals were, of course, is very challenging. And it turns out that like, if those individuals are acting at the beginning of an epidemic, it really makes a difference. Epidemics can really take off with just one or two badly placed actors at the beginning if they're doing a lot of spreading. And so for example, the first SARS, like there was a case in Hong Kong, and then the person was on a plane to Toronto, and then there was a huge outbreak in Toronto as a result. Right, so knowing information about that, whether or not you're able to stop it or not is a different question, but at least knowing information about that would be really handy.
Right, we're getting very close to the end. There are a couple of detailed questions here, which I'm wondering, Stacey, are you okay if folks if they find your email through the Ottawa University, yes, and they have particular questions about the research paper, and I think the paper, is it published online?
It is published. Yes. Okay. If you just Google me, you'll find my website, and all my papers are available.
Okay, so you can see Dr. Smith's paper there through Google Scholar, and I guess just before turning things over to Marissa to wrap up the event, I just want to give you an open question. I mean, through the conversation we've had, is there anything you'd like that's come up in you that you'd like to leave us with in terms of reflection or thought?
Yeah, I mean, I think our discussions and also we had the other day too about incorporating human behavior. This is something I'm very interested in. I have an informal background in communication and women's studies, and so I found that that has been incredibly helpful to me. But this is not something that most scientists have any experience of, right? And so I think that I've been dealing with sort of the interface between math and biology for a long time, and I know that the sort of more senior biologists, especially when I was junior, they were saying like, I went into biology to get away from math, and now it's come for us, and it's here, and it's terrifying, and we don't know what to do. And I had very senior people saying, I don't know what a matrix is. I'm terrified, and I need to know it because this is happening. And I think that same kind of march of sort of like math is basically going to walk into like, you know, kind of social science pretty soon. And both sides are like the school dance, right? We kind of don't know how to talk to each other. And this needs to change. And I think as we're talking about like the bridges that we need to build between sort of policymakers and kind of more like, you know, quantitative people, those bridges are also going to have to occur in academic circles too. And I think that, you know, like we as mathematicians are going to have to learn how to talk to people in social sciences, but I think also social sciences are going to have to kind of learn how to listen to kind of like predictions from models, and because not just listen, but also incorporate. So where we can meet together and basically build our models together, that's where we become much more powerful. And at the moment, this is a really big challenge because a lot of people understandably are very petrified of math, because I think that the way math gets taught in schools particularly is really off-putting, and it's not a great system. So you end up with only a few people who really love it taking off with it, whereas it could be something that everybody's into. That's certainly a valid way to approach math, but it's not done that way. And so there's a lot of, you know, even trauma around it. So it makes it a really hard bridge to build when people are actively rejecting your bridge.
Yeah. Well, I don't know if Monica paid you for that advertisement for the ISSP, but essentially you articulated, you know, I think the critical importance of organization, you know, these multidisciplinary, interdisciplinary organizations. And I think, you know, that's a absolutely crucial point. I think why we're all here on this, you know, on this Facebook Live event today. So I will, with that, thank you very much. It's an absolute pleasure, you know, getting it, your perspective, and I'll turn things over to Marissa.
Thank you so much.
Thank you so much, Jacob and Stacey, for this really truly fascinating and important conversation. I feel bad for having to interrupt, but our hour is up. My name is Marissa Beck. I'm the research director of the ISSP, and I'm here to say thank you to everyone involved in this event, to Jacob and Stacey, of course, but also the entire ISSP team, in particular Raphael Desordi and my colleague Brendan Frank, who have really been the brains and the operation between today's webinar. Thank you so much. Finally, thanks to all of you for being here and for joining us for today's conversation. And just briefly, I wanted to announce the next Food for Thought event will take place on the last Thursday in March, so March 25th. And for that event, that will focus all around the grand challenge of reconciliation with Indigenous peoples. Speaker will be Tosh Southwick, who's the co-owner and operator of IR Potential and also an ISSP advisory committee member. And the session will be moderated by Sandra Schillo, who is a core member of the ISSP and associate professor at the Telfer School of Business and Management at uOttawa. So we hope to see you all again at the Food for Thought event in March. And to keep up to date with all of ISSP's events, please subscribe to our newsletter and our social media channels. And we look forward to seeing all of you again soon. Thank you so much for being here. Goodbye.